السلام عليكم طلابنا الأعزاء. Our lecture is about malignant diseases affecting the uterus. Starting from the most common type of malignant diseases affecting the uterus is endometrial adenocarcinoma. Endometrial adenocarcinoma, from its name, it arises from the lining of the endometrial cavity, that is to say, from the endometrium. It is of two distinct subtypes, it has two distinct types. The commonest is the endometrioid adenocarcinoma, that is known as type 1. This accounts for the majority of endometrial adenocarcinoma. About 90% of those with endometrial adenocarcinoma are of type 1. It is characterized by being estrogen dependent. Therefore, it is frequently preceded by endometrial hyperplasia. It occurs in younger women in comparison to those affected with type 2, and it has a good prognosis. While the second category of endometrial adenocarcinoma is known as type 2 cancers, and indeed this includes all other types of endometrial carcinomas that are not type 1. Examples: serous papillary carcinoma, clear cell carcinoma, undifferentiated carcinoma. All of these types are characterized by being non-estrogen dependent. That is to say, they affect an atrophic endometrium in a postmenopausal woman. Hence, from this point, we can imagine that this tumor or this category affects those who are postmenopausal, that is to say, in an elderly aged group than those affected with type 1 endometrial adenocarcinoma. All of these types or subcategories carries a poorer prognosis than type 1. And of course they are not hormone sensitive. This figure illustrates how an endometrial adenocarcinoma looks like on a sagittal view of a uterus after a hysterectomy. This is the gross appearance of the tumor. The other types of malignancies affecting the uterus is sarcoma. Sarcoma, it is the malignancy that arises from either the stroma or from the myometrium. And this picture illustrates the gross appearance of a uterine sarcoma. As you see in figure A and B, it arises from the myometrium, while figure C is the histopathological view of a sarcomatous tissue. What about the incidence? The incidence in general of malignant diseases affecting the uterus. It has been found that they account for about 30% of all gynecological malignancies, and any woman has 1 in 90 chance of having or developing endometrial cancer throughout their life. So the lifetime risk of developing endometrial cancer is 1 in 90. The mean age of diagnosis is 53 years old. However, the incidence rises sharply after the age of 45, that is to say in the mid-40s. And there is 25% or 25% of cancers affecting the uterus occur before the age of menopause. What about the etiology? The exact causes of endometrial cancer remains unclear. However, there is a clear association with high circulating levels of What about the risk factors for the development of endometrial cancer? These include obesity, hypertension, and diabetes. And of course, all of these factors are interrelated. High levels of estrogen environment that leads to endometrial hyperplasia and eventually the development of endometrial carcinoma. Being a case of polycystic ovarian syndrome, because as you know, in those women with PCOS, there is infrequent shedding of the endometrium because of the because of the oligomenorrhea, and this will place the woman at high risk of endometrial hyperplasia and eventually the development of endometrial carcinoma. Being nulliparous, the use of unopposed estrogen therapy that is specially prescribed for a postmenopausal woman for the sake of relieving postmenopausal symptoms, for example, hot flushes, osteoporosis, etc. Tamoxifen therapy is a risk factor as well. Hormone replacement therapy. Late menopause, that is to say cessation of mens above the age of 52 years old. Being postmenopausal, as well family history of hereditary non-polyposis colorectal cancer syndrome or ovarian cancer. All of these are risk factors for endometrial cancer. You have to know that in a postmenopausal woman, although there is it is clearly known that the ovarian function ceases at the age of menopause, one might ask from where the estrogen can be secreted into the body or be formed. It is from the peripheral conversion in adipose tissue of androgens to estrogen. As well, those who are diabetic are at increased risk of developing endometrial cancer because it has been found there is an interaction with insulin like growth factor and insulin. For the elderly women who have hypertension, of course, those are factors that are interrelated with obesity and diabetes. What about tamoxifen therapy? As you know that tamoxifen is frequently used for the treatment of breast cancer post-surgery. It has a selective estrogen receptor. It is a selective estrogen receptor modulator that has an anti-estrogenic effect on the breast tissue, while it has a weak estrogenic effect on the endometrium. Therefore, although it blocks the estrogen receptors in the breast, it might lead to endometrial hyperplasia and increasing the risk of endometrial cancer by about 2.5 folds. Now there is a new generation of selective estrogen receptor modulator that is known as raloxifene, which has a lesser or no effect on. For the hereditary non-polyposis colorectal cancer, it is an autosomally dominant inherited disease or disorder. It occurs because of a mutation of a mismatched repair genes. These includes MLH1, MSH2, and MSM-SH6. It is associated with colorectal cancer, with ovarian cancer, endometrial cancer, and urothelial tumors. The cumulative cancer risk for endometrial cancer in those carrying this mutation or this hereditary non-polyposis colorectal cancer syndrome varies from 25 up to 70%, depending on the type of a mutation. What about the factors that reduces the risk of endometrial malignancies in general? These include the use of combined oral contraceptive pill, as well the use of a progesterone-only pill. Both of these types of contraceptions reduces the incidence of endometrial cancer by about 50%, and it has been found that this effect is long-lasting. That is to say, it is not while the woman is using the pill, but any woman with a history of combined oral contraceptive pill intake or progesterone-only pill intake will have this reduction in the risk of future development of endometrial cancer. As well, smoking has been found to reduce the risk of endometrial cancer development, possibly due to its anti-estrogenic effects of tobacco. Okay, what about the clinical features? How a woman with endometrial cancer might present? About 90% of patients with endometrial cancers presents with abnormal uterine bleeding, either in the form of postmenopausal bleeding, they are postmenopausal, or irregular vaginal bleeding if they are premenopausal or perimenopausal. And it is important to remember that about 10% of women with postmenopausal bleeding have a gynecological malignancy. Therefore, postmenopausal bleeding is regarded as a significant symptom in any woman because of this higher incidence of malignancy in those age group. While the common symptoms in a premenopausal woman include intermenstrual bleeding, blood-stained vaginal discharge, heavy menstrual bleeding. As well, she might present with lower abdominal pain or dyspareunia. Very rarely the diagnosis is by or accidentally following a pap smear for cervical cytology, cervical cytological assessment through a pap smear, where an abnormal glandular cytology is found accidentally. However, in advanced cancer, in those who neglect their signs and symptoms and present late during their disease, their presentation might be either with a pathological fracture of a bone because of a bony metastasis, or with clinical evidence of a fistula, for example, vesico-uterine fistula, or in the form of an altered liver function test, or presented with respiratory symptoms because of lung or distant metastasis to the pulmonary tissue. How those patients be diagnosed? Of course, starting from the examination, using a speculum examination, we can see blood that may come out through the cervix. By manually examining the uterus, an enlarged uterus may be felt. And of course, using transvaginal ultrasound scans will allow a quick and accurate assessment of the endometrium. And it has been found that an endometrial thickness that is measured about 4 mm or less will generally exclude endometrial cancer as a cause of their current bleeding in a postmenopausal woman, while those with an endometrial thickness of about 5 and more will require further investigation to rule out the possibility of endometrial malignancy. And this is best done by doing hysteroscopy and biopsy from an abnormally looking area. This picture illustrates how a speculum is introduced through the vagina, and the cervix can be viewed, of course, easily. And here a brush is used for cytological assessment of an abnormal cell at the cervix. So accidentally, as I said, the presence of an abnormal glandular tissue cells during cytological assessment of a pap smear may alert the possibility of the presence of endometrial adenocarcinoma. And this figure illustrates how a bimanual examination of the uterus is being carried out. One hand is introduced through the vagina, while the other hand is applied on the uterine fundus through the abdominal wall. And this figure, or this view, represents a transvaginal ultrasound view of an endometrium. In figure A, as you see that there is an abnormal thickening of the endometrial tissue, or and it is an irregular thickening that is most likely caused by an endometrial carcinoma, while in figure B the thickness of the endometrium is much less. What about the hysteroscopy? As you know that hysteroscopy, it is an instrument, or it is an endoscope that is used to view the inside of the uterus, the uterine cavity. It can be performed in the outpatient settings or as an inpatient under general anesthetic. This will allow direct visualization of the whole endometrium, and of course any abnormal area visualized can be biopsied directly. Endometrial cancer can only be diagnosed by histological examination and confirmation of a biopsy taken from an abnormally looking area. And of course this biopsy is better taken under direct visualization, as I said, via the hysteroscope. But if this facility is not available, another ways of sampling the endometrium can be applied, for example, using a pipe only in the outpatient setting under nothing, or under general anesthesia by doing dilatation and curettage. And this picture illustrates a hysteroscopic view of an endometrium. As you see, there is an abnormal thickening of the endometrial lining. What about the results that should be obtained from the histological report? This should provide information about the cancer type, for example, an endometrioid adenocarcinoma, which is the commonest, as I said, that is referred to as type 1, or type 2, that might include the subcategories of serous papillary carcinoma, clear cell adenocarcinoma, etc., or undifferentiated. As well, the report should provide an information about the grade of the tumor, that is to say whether it is grade 1, 2, or 3, with grade 3 equating to a high grade. And of course this information is required to decide the optimal surgery or surgical intervention that should be done for any particular patient, as well will affect the oncology management. Following a diagnosis, we have to stage the disease, because this will affect our approach in managing those patients. And as you know, magnetic resonance imaging is the best imaging technique that is used to visualize the soft tissue. Therefore, it gives a useful information regarding the extent of the disease. Of course, chest X-ray should be arranged in order to exclude any distant spread of the disease. As well, cystoscopy should be arranged, which is an endoscopy of the bladder, sigmoidoscopy, which is an endoscopy of the rectum and sigmoid, and of course examination under anesthesia should be arranged, and all of these are permitted. as staging procedures and will help to decide the type of surgical treatment that should be offered to any individual woman. For the staging of carcinoma of the uterus, it is divided into 4 stages. Stage 1, when the tumor is confined to the uterine body, while stage 2, when it is invading the cervical stroma. Stage 3 involves local and or regional spread of the tumor. And stage 4, as in any tumor, is when the tumor is extended into the distant areas, or when it does invade the bladder and or the bowel. For stage 1, it is further subdivided into stage 1A and 1B. 1A, when less than 50% of the when there's less than 50% invasion of the uterine wall or myometrium, while stage 1B, when there is an invasion of more than 50% of the uterine myometrium. As I said, stage 2 is when the tumor invading the cervical stroma. Stage 3, when there is a local and regional spread of the tumor. And this can be classified into 3A, when the serosa of the uterus is invaded or involved with the tumor. 3B, when the vagina is affected or invaded with the tumor and or there is parametrial extension of the disease. 3C, when there is metastasis to the pelvic and or para-aortic nodes. And as I mentioned to you, that stage 4 is when the tumor invades the bladder and or the bowel, or when there is a distant metastasis. For the management, of course, surgical removal of the tumor remains the main primary intervention in endometrial cancer. However, the extent of surgery depends on the grade of the disease, MRI staging, and the patient comorbidities. That is to say, whether they are fit for major surgical intervention or not. The standard surgery is total hysterectomy and bilateral salpingo-oophorectomy. That is to say, removing the uterus and with adnexa. This can be performed either abdominally through laparotomy or laparoscopically, or vaginally assisted laparoscopic hysterectomy, or via the robotically done. This figure illustrates how a uterus is going to be removed in different types of hysterectomy. As you see that the first figure, which is on the on the left and above, represents total hysterectomy without salpingo-oophorectomy. The next figure to the left represents total hysterectomy with unilateral and or bilateral salpingo-oophorectomy, while the figure below represents radical hysterectomy. Radical hysterectomy is when the uterus is removed with a nearby tissue, that is to say the parametrium and the upper vagina as well. In general, if the patient is low grade, grade 1, 2, and MRI staging suggests the disease less than stage 1B, that is to say, when there is less than 50% invasion of the uterine wall, the standard surgery will be adequate. That is to say, doing the total abdominal hysterectomy, hysterectomy with bilateral salpingo-oophorectomy. While when the MRI staging suggests cervical involvement, that is to say, stage 2 and above, a radical hysterectomy with pelvic node dissection can be performed. If the tumor is high grade, grade 3, or of papillary serous type, as it is shown via the histopathological report, pelvic and or para-aortic node dissection, as the risk of nodal disease can be as high as 30% is indicated or recommended. However, the role of node dissection remains contentious. For the adjuvant therapy, post-operative radiotherapy can be given. This will reduce the local recurrence rate, but this will not influence the 5-year survival of any woman with endometrial cancer. Strategies include either by using the local radiotherapy to the vaginal vault that is given over a short period of time in the form of a high-dose radiotherapy, and this is known as well brachytherapy. While the second strategy of giving the radiotherapy is via using the external beam radiotherapy, and this is given for locally advanced disease stage 3 in combination with high-dose radiotherapy. This is known as teletherapy. This figure represents the brachytherapy. As you see that there is a cylinder that is introduced inside the vagina, and it emits a high dose radiation through the vaginal vault. While this figure illustrates the teletherapy. What about the chemotherapy and hormonal therapy? Chemotherapy is given for metastatic disease to combat the risk of distant spread, as well as hormonal therapy. The commonest drugs or cytotoxic used for the treatment of endometrial adenocarcinoma is cisplatin and doxorubicin, while medroxyprogesterones are the most commonly used hormonal therapy. What about the overall 5-year survival rate for endometrial cancer? It is about 80%, being 88% for stage 1 disease, but it is reduced to 16% for stage 4. What about the adverse prognostic features? Of course, advanced maternal age, more than 70, high body mass index, grade 3 tumors, papillary cirrus or clear cell histology, lymphovascular space involvement, nodal metastasis, distant metastasis. I will give you some few points about the second type of malignant diseases affecting the uterus, which is the sarcomas of the uterus. These are rare tumors and account for just 5% of all uterine cancers. They can be classified into pure sarcomas, mixed epithelial sarcomas, and heterologous sarcomas. For the pure sarcomas, this category includes those arises either from the endometrial stromal cells, known as endometrial stromal sarcomas, or from the myometrium, known as leiomyosarcoma. While the second classification is mixed epithelial sarcomas, known as carcinosarcomas. The third one is heterologous sarcomas, and the most common example of which is rhabdomyosarcoma, which may present in children as a grape-like mass protruding from the cervix. Thank you for your listening. Goodbye.